Good afternoon. Thank you for joining us. My name is Laura Charles Horn, and I am the Capacity Building and Development Manager at the Office of Minority Health Resource Center, which is a nationwide service of the U.S. Office of Minority Health. Welcome to the National Black HIV/AIDS Awareness Day webinar. In commemoration of its 18th year, the Office of Minority Health Resource Center presents to you Fact or Fiction, Debunking Myths in the African American Community. Dr. Tamara Henry is a Senior Program Analyst at the Office of Minority Health Resource Center and will be our guest speaker for this webinar this afternoon. Dr. Henry is a public health professional who comes from a diverse background, ranging from foreign and domestic consulting services to state and local government programming to academia. She spent over a decade in state and local government providing technical assistance, addressing health disparities, as well as monitoring and evaluating health promotion programs in underserved populations. Moreover, she brings over 20 years of experience in the field of HIV and AIDS and has done extensive work in African American communities in New York City as well as Washington, D.C. In addition to her work with the Office of Minority Health Resource Center, Dr. Henry is a teaching assistant professor in the Milken Institute School of Public Health at the George Washington University. Thank you all again, and Tamara, you can begin.
Yes, thank you. Good afternoon, everyone. Thank you again for listening on this webinar. It's great to see so many people that have registered and are also tuning in. Most of us who decide to work in HIV, especially around underserved populations, those being African American and or Latino, we are committed to this work and oftentimes not doing it for the money. So today's learning objectives are, next slide, please. To know and understand the myths about HIV/AIDS in the African American community, to provide answers to common myths about HIV/AIDS in the African American community, to think about utilizing a socio-ecological approach to HIV/AIDS in the African American community, and we'll conclude with identifying evidence-based programs that may be replicated in some of your communities. Next slide, please. As most of you may know, currently there are over 1.2 million people in the United States who are living with HIV. 1 in 8 of them are unaware of their infection. Men who have sex with men account for 82% of the HIV diagnoses among males and 66% of all diagnoses in 2016. Although African Americans are only 12% of the population, they account for 43% of HIV diagnoses, with the age groups between 25 and 29 representing the largest diagnosis rate. Next slide. So I'm going to discuss debunking HIV myths. One of the reasons that I wanted to have this discussion, especially on the National Black HIV/AIDS Awareness Day, is that while HIV has been on the scene since 1981, we know that it began as a primarily gay-related immunodeficiency syndrome in white gay men, and it has evolved over the past 37 years to become really a disease that is affecting Black people disproportionately. And in the work that I do in the jail population, as well as with African American youth, we see a number of these myths continuing to fester in 2018. Despite the technology, despite the education, we're still continuing to hear about these myths. So the myths that you'll see are not all of the myths, but there are a few that I often hear in the work I do. Next slide, please. How is HIV transmitted? Contrary to some myths, it's not transmitted by air, water, saliva, sweat, tears, kissing, insects, or even sharing toilets, foods, or drinks. Instead, it's only transmitted through the following: blood, semen, pre-seminal fluid or pre-cum, rectal fluids, vaginal fluids, and breast milk from a person who is HIV positive. Next slide. Some of the myths that I typically hear in vulnerable populations include things like, I can get HIV by being around someone who's HIV positive, or only gay people get HIV, again, because of how the disease started and in specific gay communities. That has resonated still with a lot of people of color, that this is a gay disease, even though they may in fact know other people who look just like themselves that may be positive. We still hear that a lot. HIV is spread by kissing, obviously, because saliva is a bodily fluid. But again, saliva is not what HIV is transmitted in, so that's another common myth. I would be able to tell if my partner or I was HIV positive. So eyeballing someone and thinking that they in fact have HIV or don't have HIV just by looking at them. I'm straight and I don't inject drugs, so I can't get HIV. Again, you being straight has nothing to do with whether or not you get HIV. It's because you're having unprotected sex or sharing unclean needles with someone who may be infected, and you have to know your status regardless. HIV is a man-made disease brought into poor communities. This I hear more often than not. Up to a focus group that I did last summer, I am still hearing this in urban communities, that HIV is man-made. It's a complete conspiracy to wipe out a particular population, and that is not in fact the case. I can get HIV from oral sex. We don't have any cases to date that HIV has been transmitted via oral sex. But again, the idea of bodily fluid being exchanged, whether it's in the mouth or any other orifice, have people believing that oral sex is definitely one of the routes in which one can contract HIV. My partner and I are both HIV positive, so there is no need to use a condom. And we know that you should still use a condom if you and your partner are HIV positive due to the various strains. Next slide. Can the HIV virus survive on surfaces outside of the body? HIV doesn't survive long outside the human body, such as on surfaces. However, it can live in a used needle up to 42 days, depending on the temperature and other factors. HIV transmission has not been reported as a consequence of contact with spillages of blood, semen, or other bodily fluids. Next slide. As it relates to our providers, they happen to be the first line of individuals that come into contact with persons, patients, or clients who may or may not be HIV positive. And what we want them to avoid questions like this: are you married? When did you last make love? Did you have a one-night stand with your boyfriend or girlfriend? Have you ever been unfaithful? Have you had a one-night stand, just in general? But instead, we want to provide our healthcare practitioners with better questions to ask so that their clients will feel more comfortable and more inclined to tell the truth when these questions are asked. So here are some better questions. Do you have a regular partner? When did you last have sex? Was that with a regular partner? How long have you been with them? Do or did you use condoms at all? Have you had any accidents or slip-ups? When did you last have sex with anyone other than that particular partner? And is your partner okay? So we really do not want to come across as providers like we are judging the population that we are supposed to be treating. We want to ask questions that enable and empower the client to tell the truth about their sexual behavior and really not feel like they are being judged. Next slide, please. Some other myths involve Black men who have sex with men in terms of whether they do or do not exhibit higher risk factors. And these risk factors may include drug use, lack of condom use, and number of sexual partners. So the answer is no. Black men have been found to have fewer sex partners, fewer had ever engaged in intentional unprotected anal intercourse, and more Black men use condoms at last anal intercourse. However, I think that anytime we discuss HIV, regardless of the population being heterosexual, homosexual, and or African American, we need to keep in mind the social and structural factors that play a larger role in HIV. So the stigma and internalized homophobia of certain parts of the African American community plays a role in whether people come out and how they decide to seek help. The prevalence of sexually transmitted infections in that given area, the sexual networks and partnership characteristics that are among that group, as well as disclosure. Will you disclose your status if you know that it will be accepted widely, or do you keep it to yourself because of the stigma as a result of people not having the knowledge about HIV? Socioeconomic factors, especially related to poverty and access to quality care, always play a role into how people seek care for HIV treatment. And the lack of access to preventative services and treatment and bisexuality are a few of the social and structural factors that play a role in HIV, especially in the men who have sex with men community. Next slide, please. So an example that was taken from the Bay Area AIDS Education Training Center looks at some of the social and structural factors in the case study of Antoine. He's a 30-year-old African-American man who has sex with men. He tested in 2014, and he requested an HIV test due to having unprotected sex with an HIV-positive man who stated he was undetectable, meaning that he too tested negative at this point. His last negative test was a month ago. Antoine is a frequent tester, so he seems to test for HIV on a regular basis, which would lead one to believe that he is engaging in some high-risk behaviors. He took a rapid HIV test, and it was negative. The viral load was sent, and it came back that he, in fact, was HIV positive. The healthcare provider linked him to care, and in doing so, we found that there were a number of barriers to linkage. So initially, he had a suicide risk assessment given to him. He was given medication on the spot because we want to make certain that one is immediately treated upon them finding out they have HIV. However, he had some mental health issues with depression and a past suicide attempt. It's also important to note that the mental health component of HIV, being diagnosed with HIV or even engaging in high-risk behaviors, often go unnoticed. We don't tend to pay a lot of attention to that, which is something that we should definitely start doing more when it comes to relating to and addressing the social and structural factors. The other barrier to care was his insurance. He started the application for the Affordable Care Act covered in California, and he was unable to refill his prescription for the antiretroviral medication. Last but not least, the follow-up. He had 2 follow-up visits, and then he missed 4, canceled some visits, and even with numerous outreach efforts, they were unable to contact him and follow up with him. He's been off his medication for 3 months, and then he was finally linked to Kaiser and restarted his medication and continues to deal with his ongoing depression. Next slide. So when we think of Antoine, all of us come from different fields, from education to community-based organizations. We should think, or rather consider, the socio-ecological framework, where we have a number of different sources that we can use and a number of different approaches that we can use to address Antoine. So we know that he has some mental health issues and he's dealing with an HIV-positive diagnosis. So on an interpersonal level, we want to make sure that he has an increased knowledge, his attitudes and his behavior changes. One can actually live with HIV, and you can live well and healthily with HIV if you know about the resources and you have access to care. Another tier is the interpersonal processes and primary groups, which can include your formal and informal social networks, as well as your social support systems. So a number of other diseases, what comes to mind immediately, a disease like cancer, there are a number of social support groups and systems that are available to people, and connecting Antoine to a support group for other HIV positive men who have sex with men and bisexual men as well could be really helpful to having him cope with his depression as well as his diagnosis. The institutional factors, so for those of you who are community-based organizations and do this for a living, whether your in-reach or outreach is formal or informal, but also being that entity that can connect Antoine not only with care, but providing it for all individuals who are HIV positive. Community factors refers to relationships among organizations and institutions. Community factors also really help with dispelling myths and creating, I would say, reducing the stigma, but also creating the opportunity for discussion in communities around HIV and what it's doing in the African American community. So really normalizing the discussion, not only around sexuality, but how this disease is disparately affecting people. So normalizing the conversation around HIV, which could help to reduce stigma. And then from a policy perspective, both local, state, and national laws that help people that have HIV by connecting them to care, which could mean an expansion of Medicaid in some areas, or just making certain that in this case, Antoine had Kaiser, but having other entities like that, so that when a person tests positive, we as a community-based organization, healthcare providers, social workers, case managers, and the like, know what the current laws are, because we try to act a lot of times like public health is in a vacuum and you stay in your lane, which is true. You do what you can, but we have to also understand the influence that policy and legislature has on the drugs, on the type of treatment that people can receive, especially when they are uninsured and or underinsured. Next slide, please. So the latter part of this discussion, we're going to talk about various evidence-based programs in African American populations and how one implements these programs. A few of them you'll see actually utilize the socio-ecological framework to address HIV in their respective communities. Next slide. The Empowerment Project is a community-level intervention for men who have sex with men, ages 18 to 29 years old, that address peer influences on sexual behavior and mobilizes men to use condoms. The community-based organizations that were implementing the Empowerment Project participated in this study and were assessed at baseline, 6 months, 1 year, and 2 years post-baseline. Some of the factors for successful implementation included an alignment regarding the understanding and believing in the program's goals and methods at multiple levels. So we're back again to that socio-ecological framework where we're not working in a vacuum, but we're really trying to touch the interpersonal level, the community level, the social support level, as well as the political realm. The coordinators, supervisors, executive directors, funders, and national HIV policies all influence implementation success. Next slide. Other factors included the prevention support system that addresses facilitators or barriers to implementation, as well as address the right people to do the following. Translate intervention into practice. So it's one thing to have your study written out on paper and it sounds beautiful, but what does it look like in practice? Is it actually working? Knowledge about the intervention, belief in the efficacy of the intervention, the desire to change. So this is measuring all of this in that particular population at baseline, 6 months, in 12 months. The appropriateness of individuals for the coordinator positions, evaluation of intervention, as well as the organizational stability. So consider it from the perspective of those who are at community-based organizations and the type of work you're doing. We want to make certain that anyone who has decided to go into conducting any sort of HIV work, working among those who are positive, we need to be certain that they are culturally competent and that they are effective and really understand the big picture, the socio-ecological portions of it, but also the social determinants that their clients may be encountering. So the entire ecological system of the intervention does affect implementation. It starts with who those clients first come into contact with and what the treatment is going forward. Next slide. Many Men, Many Voices happens to be another evidence-based intervention. It's an HIV STD prevention intervention which seeks to reduce sexual behaviors and increase protective behaviors among Black men who have sex with men. The intervention addressed social determinants of health in terms of stigma, discrimination, and homophobia that can often influence the health and well-being of Black men who have sex with men who are at high risk for HIV infection. There were 7-session small group interventions for Black men who have sex with men that aimed to reduce the behavioral risk for acquiring HIV and other STDs and increase health protective actions. Next slide. Some of the results from Many Men, Many Voices include those who participated in the small groups reported a 25% greater reduction in the number of male sex partners at the 3-month follow-up assessment. 66% reported greater reduction in the number of episodes of unprotected anal intercourse with casual male partners at the 6-month follow-up assessment, and there was a 51% greater reduction in the number of episodes of unprotected insertive anal intercourse with casual male partners across the entire study period. Next slide. Wang et al. Looks at the impact of teacher modifications of an evidence-based HIV prevention intervention on program outcomes. So the modification of and deviation from evidence-based practices often lead to poorer health outcomes. Using mixed effects modeling revealed that omitting core HIV/AIDS education activities due to time had negative impacts on all 4 student outcomes. Consistency and fidelity in implementation of an intervention in the fields lead to better outcomes. Some interventions are specifically designed for adaptation. So again, this goes back to who we have in our classrooms, in our community centers, in our community-based organizations that are implementing these programs. A lot of times we make assumptions about what people know based on what they've told us, but it's really important to note that to implement an intervention with fidelity, it's important that individuals are well trained, they are comfortable with the material, and that they're okay with answering questions, or if they don't know it, not answering and getting the answer and telling the principal investigator or the person who's leading the study to make certain that they are implementing it in a manner that people are receiving it but learning and hopefully practicing the said behavior so that we have positive health outcomes. Next slide, please. Another pretty innovative and creative intervention was this video game intervention for sex risk reduction in minority adolescents, which was also a randomized controlled trial. This was a theory-based digital health intervention in the form of an interactive video game that would improve sexual health outcomes in adolescents. There were over 330 participants. They were randomized by an intervention group and a control group split in half. About 295 or 88% were racial and ethnic minorities. And we had a pretty high percentage of boys, with over 50% being boys. The mean age was about 12.9, so close to 13 years old. And we saw that over the 12-month period, the intervention group demonstrated improved sexual health attitudes overall compared to the control group. Next slide. The next slide looks at PrEP use and HIV/STI incidence in a clinical practice setting. So I think I'm going to make the assumption that most of us know what HIV PrEP is, HIV pre-exposure prophylaxis, which was approved for daily use for folks who engage in intercourse with those who may be high risk, and you need to be HIV negative before you start PrEP. So analysis of PrEP use and HIV/STI incidence in PrEP users in a large healthcare facility, specifically Kaiser in San Francisco, between 2012 and 2015, looked at over 1,000 referrals were given for PrEP, and about 801 individuals within an intake visit took it. So 657 initiated PrEP for over 7 months. And some of the key findings were that after 12 months, 50% were diagnosed with any STI, 33% a rectal STI, 33% chlamydia, and 28% gonorrhea. However, at follow-up, there was no HIV diagnosis for 388 people. So after 6 months of PrEP, self-reported condom use decreased in individuals by 41%. Next slide, please. Another pretty well done study, the HIV Prevention Trials Network, looked at PrEP uptake and use by Black men who have sex with men in Washington, D.C., Los Angeles, California, and Chapel Hill, North Carolina. There were 226 HIV negative Black men who had sex with men. They were less than 25 years old. About 40% were less than 25. 27% were unemployed, and about a third had no health insurance. 79%, so 178 out of the 226, accepted PrEP and counseling sessions, and about 96% had an HIV-positive partner. And the casual partners of an unknown or HIV-positive status was about at 86%. So out of this total, about 92% completed 12 months of PrEP, and we had adherence that was greater than 90% in terms of the self-report. And of that number, we had 5 seroconvert, where 2 out of the 5 reported discontinuing PrEP at 50 and 272 days prior to seroconversion. Next slide. Some other notable evidence-based work in Black men who have sex with men populations, as well as heterosexuals. One that's pretty familiar to those who have community level or community-based organizations is the popular opinion leader, which is a community level intervention that involves the identification and training of opinion leaders to encourage safer sex norms and behaviors. So basically identifying the persons who are the key informants and leaders of the community and almost training the trainer so that, again, we normalize the talk around HIV and stigma and help to reduce that stigma so that people will get tested and be more comfortable disclosing. DUP, or Defend Yourself, is tailored specifically for African American men who have sex with men and addresses their unique cultural experiences, which again, we have to be able to talk about the experiences of heterosexual and homosexual persons in the African American community and what that may mean. Second. Next slide. Okay, I lost my picture. One moment, please. 1 second, I am having slight technical difficulty. I apologize. 1 moment. Other notable evidence-based work in young men who have sex with men populations and heterosexual African American populations include the AIDS Project East Bay, which is comprised of a youth-directed community-based outreach system and referral network. It provides direct linkage into care in an adolescent HIV specialty clinic and psychosocial retention activities, because age-appropriate care is important when we are discussing HIV, especially among those who are youth. And Working for Togetherness is another program that's pretty well known, where they conduct outreach and in-reach strategies to deliver HIV prevention messages and increase early detection and treatment of HIV-positive youth, to create and operate a youth empowerment center. So again, as we become more culturally competent, as we deal with diverse populations who happen to be Black and are affected by HIV, it's important to note that not one size fits all, that we really need to tailor our messages if they're going to be towards heterosexual women, towards homosexual men, as well as towards our adolescents who may be coming out or expressing various behaviors. We, as practitioners, as healthcare providers, as educators, need to be able to communicate with them in a way that does not discriminate and in a way that really gives them the knowledge that they need to have, but also that they can trust us and that we are the resource that they should come to if they want to discuss any of these issues. Next slide. You'll have a few works cited in the next few slides, but I am open to taking your questions. So if you have any, that concludes the presentation of debunking myths in the African American community for NBAD. If you have any questions, please feel free to ask. Thank you. Okay, I can't. Okay, so the first question reads, perhaps I was expecting something different from the title of this webinar, but how do we go on to debunk the myths that you listed in the beginning? What approaches do we use? For when I confront these myths head on, often it feels like people hunker down and hold on to these beliefs rather than let them go. Thank you for your question. I think that a couple of the things, I looked at not only the myths, but what has been done to address these. So to your first question, what approaches do we use? I think that we have to talk about it, because these myths, regardless of the education, in some communities there is comprehensive sexuality education, in others there isn't. So I've heard these myths from persons who are 13 to those who are 65, and I think that talking about it in a manner where it's not judgmental, but giving them the facts. I know it's hard to believe that people still think in this manner, but there are reasons behind it, and there are stories that have been told for generations that continue to be perpetuated, because from generation to generation, the truth has not been told. So I would stick to my story. I'm still going to tell the truth, regardless of whether they continue to hunker down on these beliefs rather than let them go. I think it's also consistent messaging. So if you're able to get this particular population in a room together, I would also consider, if you're working with youth or populations that resemble each other in terms of age and or life experience. For instance, I have dealt and worked with and educated women who were incarcerated, where this came up, where I had at least 15 women telling me that HIV was a conspiracy, and all of them were on the same page. And then the individual who told us that she was HIV positive, she said it was not a conspiracy, and she spoke about how she contracted HIV, and it seemed to be the only thing that would get through to these women, that somebody that looked like them, who happened to be incarcerated, who was actually living with HIV, said that it was not a conspiracy, and in fact spoke directly to the behavior that led to the HIV. That seemed to resonate far more with the population than any of the education that I was giving them. So I hope that helps to answer your question. Okay, let's see. Thoughts on mass incarceration? I have a lot of thoughts on mass incarceration, but what I can say, because it's not necessarily as relevant to this presentation, I can say that a lot of people are diagnosed upon entry. There are several people that I work with who did not know that they were HIV positive until they entered the correction system. And not only did they learn that, at the same time, they learned that they had another comorbidity in terms of mental health issues. So I think that those are not myths. That's actually what's happening, and that's because of a healthcare system that's not working to its fullest potential. Mass incarceration, it doesn't really have enough to do with this particular presentation today, but I would be happy to talk with you offline about it. In regards to the age-appropriate interventions, is there anything out there for Black elders in terms of outreach, education, intervention, and support? Now, I don't have that data at my fingertips. I think it's an excellent question, because we do know that there are a number of Black and brown persons who are over 55 who are finding out they're HIV positive. And I know that the CDC does have some recommendations. I don't have it at my fingertips, but I would encourage you to look at cdc.gov and look at some of the evidence-based practices that they have for persons who are over the age of 55 and learn that they are positive in HIV. Thank you. Next question reads, you mentioned how people have different ideas about the transmission of HIV. Are you in any way saying that there's not enough awareness about the disease? Well, I am saying that, yes. Part of it, again, because I'm an educator, I don't understand how there's not enough awareness about the disease, but every time I am in different settings, whether it's the university setting, whether it's the correctional facility, I find that people think they know, and then they don't know anything at all. I think that what happens oftentimes, depending on your population, which is why we call this presentation Debunking Myths, is you find that there are some populations who have been inundated with this information, and they can tell you, like the back of their hand, how it's transmitted, how you get it, how you don't get it. But we don't see that knowledge translating. So it's like you're literally regurgitating the information that I told you, but we don't see that practice actually happening, which is part of the issue. So no, the knowledge is out there. I mean, they get it in school. Some students get it in school. Some college students get it in school through me. But what we're finding, it's still not being applied in their daily behaviors. So while the information is there, that lack of application means that there is a gap that we are not filling well. The next question reads, how do we empower agencies to step outside of their comfort zones to engage in culture? How are we defining cultural specific services? So I'll answer the latter question first. I think that our goal in terms of how we define cultural specific services is who your community-based organization decides that they are going to help. What area, what group, what race or ethnicity are these individuals, and how do you make certain that all of your employees understands the socio-ecological factors, but also the social determinants that occur in this population? How do we empower agencies to step outside of the comfort zones to engage? I think that is really a top-heavy approach in terms of empowering. When we use the word empowering, it suggests that everybody is on the same level and we are all committed to this issue. I would like to believe that, but I think a lot of times that is not the case, especially when it comes down to certain diseases. We all aren't on the same page. I think that it's important for the leadership to lead by example. So if we do want to make a concerted effort to engage in a particular culture or engage with a particular group, that it's really, really important that we move the agency in that direction, that we build in various professional development and training opportunities so that we all become more comfortable with a particular population and or culture and move in that direction. Next question. Thank you for your presentation. I've been a nurse case management position for about a year, and I'm literally waiting for the shock value to wear off. Although this is what I've wanted to do my whole nursing career, what suggestions or words of encouragement would you have for those in similar roles and often feel discouraged about finding clear solutions? So I am glad that you're a clinician and that you're on this call. I think that the work that you do is very important and should not in any way feel shortchanged. You are making a difference. I think a lot of times when you're in these positions that seem so overwhelming and you can only reach one person at a time, you feel like you're not doing enough. You are doing enough. I would really encourage you just to stick with it. You'd be very surprised that that change that you're making in one person's life is changing a number of other people, not just that one person. So I would strongly encourage you to just stay in the fight. We need people like you. We need clinicians. And I'm just glad about the work you're doing. Thank you. All right. Next question reads, Black women are one of the fastest growing groups of individuals being diagnosed with HIV in the United States. This presentation largely focused on men who have sex with men. Are you aware of any programs that are working to educate either Black women about this risk or healthcare providers on the increased risk for this population? Thank you for your question. You are, in fact, correct. African-American heterosexual women are one of the fastest growing groups of individuals being diagnosed with HIV. And yes, most of the evidence-based work right now involves men who have sex with men. Again, I would direct you to cdc.gov. They do have evidence-based programs for African-American heterosexual women for those who are diagnosed. I would share that with you, and there are a few other community-based organizations that if you email me, I can respond to you directly regarding some of those evidence-based programs that exist. And you'll see at the end of the PowerPoint, there is an email, info@minorityhealth.hhs.gov, for any questions that you have that may not have been answered in the time allotted. Okay, scrolling through. What way, another question reads, what way do you think can be the best way to create outreach in an online setting to the minority community? Have you seen any recent successful minority outreach online? So thank you again for your question. There are some really creative things going on in social media platform for young minorities, especially the adolescent community, through Snapchat, The video game was one of them, and I think somebody asked about the video game. There is a source cited at the bottom of the video game for those adolescents. I think that as educators, that's really important for us to note that if we want to reach younger people, especially in the minority group, that utilizing technology is definitely one of the best ways to reach them. So we want to continue to do that by looking at some of the evidence-based measures. Now, what I can say is I haven't seen any data in terms of Snapchat and Instagram, but through Facebook, we have a number of sites that people follow and hear stories about those who have been HIV positive. But one of the things that we come back to when we talk about technology and online resources, at the end of the day, what we're hoping is that you not only gain the knowledge from the information that we're providing, but that knowledge that you have gained, that you're applying it to your health behavior and hopefully ensuring better health outcomes. There are a few resources that we have that are relevant to that population as it relates to online communications that I can provide for you if you email info@minorityhealth.hhs.gov. Next question reads, how can we educate non-Blacks in the field of public health, and how do we counteract microaggressions? I think that's an excellent question. Again, thank you for your question. What often happens when we, especially around the research in this field, there are a number of non-Blacks who conduct this research, most of which I referred to in this presentation are persons who happen to be non-Black that work in the field every day. I think that there are a couple of things. So as I stated in the previous question, we really need to get folks to be trained in this particular area, because what happens is you may have the knowledge, which is great, knowledge of HIV, even knowledge of the prevalence and incidence in communities are fantastic. But if you've never worked with this population, you don't know any other people of color, you should really take a step back to learn more than HIV-related information about a particular culture. You should really plan to have some sort of professional development where those who are researching on communities of color understand the poverty and the other things going on in those communities, those social determinants, those syndemic factors, before they decide that this is what they want to do. Because oftentimes what we find is there are a number of microaggressions because you have a researcher or a principal investigator or the person who is just leading the study that thinks they know everything and that they have this all together because they've been doing this research and have no clue of how to really interact with said population. So as it relates to microaggressions, I think those are just things that we have to talk about on a regular basis. We have to address them in a competent manner and ideally address them without emotion. So when the microaggression is happening, we need to talk about it then and not wait for it to mellow out, because a lot of times people don't even know what their microaggressions are. They don't know what they might have done to offend you or the population that they are interacting with. And if we want to do real work in HIV and we want to see these disparities reduced, it's especially important that we have these discussions right away and alert people to these behaviors that they may not be initially aware of. Okay. I think this is going to be the final question. I work in public health, and I've seen many times in the LGBT spaces that there will be microaggressions towards Black, gay, and bisexual men. how can we, same question, how can we better educate or counteract these microaggressions among Black men who have sex with men? I think that, again, similar to the last question that I answered, it's really about education. A lot of times people don't know that they have these microaggressions, and oftentimes we don't tell them that what they're doing is problematic. I really do think that it's important from the leadership on down that we have courses on implicit and explicit bias and things that are definitively across the board microaggressions that people do not realize because they've been doing it forever, and they don't, even though they work with this population every day and on a regular basis, they still don't notice what they're doing. So we need to be able to call that out and have professional development trainings and culturally competent, culturally sensitive trainings where people can become more aware of their behavior. And last but not least, there is a question that just came in, at least I just received it. We are working with the Latino HIV positive adult community here in Sunset Park, Brooklyn. Do you have any relevant resources or data that supports debunking myths for Latinos? I am certain that I can pull that for you. I don't have it at my fingertips, but I will definitely, if you email me at info@minorityhealth.hhs.gov, I will pull those for you, and I'll have that for you later. Thank you all for your questions, and thank you for being a part of this webinar. I hope that we continue to fight this fight against HIV for all people of color who are affected by this disease. Thank you for the work that you do. Have a good day.
Thank you, Tamara, and thanks to everyone again for tuning in. We really do hope that you found this information to be useful in your respective work and communities. Again, there were a lot of great questions that we were unable to address all of them in the time allotted. However, those questions will be forwarded to Dr. Henry, or you can reach us at info@minorityhealth.hhs.gov, and she will be able to receive those as well. On the slides, just as a note, there were several ways for you to stay in contact with us, and through the email or the phone number to be able to get additional resources or services, but also know, given that a lot of the questions had to do with data related to minority populations, the Office of Minority Health Resource Center also has the Knowledge Center, which is the largest repository of health information related to minority populations. So you can also request information specific to the latest data, article, and research for particular health information through those ways as well. Feel free to also connect to us through social media and see what additional activities are being planned by the Office of Minority Health or the Resource Center itself. But thank you again, and we hope you enjoy your day. Please know a brief survey on today's presentation will be available closing the webinar, and we'd like to thank you in advance for your valuable feedback, as it helps us to continue to provide similar educational resources for communities that we serve. Have a great day, and thank you again. Thank you, Dr. Henry.